Thank you very much for joining me. I'm going to discuss tonight current concepts in the treatment of multiple sclerosis, or called MS. I'm Dee Silver. I'm a neurologist. I've been at Scripps Memorial Hospital, La Jolla, California, for over 40 years. Today, we really need to know about our disease. We have to be our advocate, and we're going to need to help coordinate our treatment because of the changing healthcare system. The outline of my MS talks have been part one. It was about epidemiology, signs and symptoms, and the pathophysiology. Part two, which we're doing now, is going to talk about some about the pathophysiology, but we're going to mainly discuss mechanisms of action of the disease-modifying therapy. And we're going to talk about immunomodulators, and we're going to talk about immunosuppressants, two different types of MS medication. I'd like to review the EDSS, which is a scoring system that accesses the course of the disease, that tells us in some way how we're assessing the progression of the disease if it does progress. You can see on the bottom, 0 is when the patient with MS has a normal neurological exam. And then it goes all the way up to 10. But there are several significant changes that are important. For example, 2 shows minimum impairment. Number 4 shows the impairment is relatively severe, but a big marker is 6, where the patient has need of walking assistance. And that is a significant marker in many of the considerations of treatment and in clinical trials. The natural history of MS is very important, and this patients really have to understand, as does their caregivers and their family. So the natural history of MS involves two important aspects: relapses and remissions. And importantly, not all remissions completely clear. It's a variable degree of recovery from these remissions, and it's thought about 25% of the patients will have 1 point increase, meaning worse, of the EDSS, and about 50% will have about 0.5 increase. So it's important to document relapses and remissions. Importantly also about the natural history is the MRI. And we know the MRI oftentimes has changes in it prior to the first clinical symptoms. But for every clinical associated lesion there is with a symptom, then there oftentimes are 5 silent lesions that occur in the MRI. And this happens, and there is accumulated burden on the MRI. The natural history of MS is somewhat variable, but before treatments, it was thought that most patients go on to secondary progressive MS in about 11 to 19 years after the first onset of the disease. This slide shows us the 4 types of MS, and this is crucial to understand. A relapse or attack is a period during which your symptoms, the patient's symptoms, worsen or new symptoms occur. So in the upper left-hand part of this slide, you'll see the relapsing remitting MS pattern. The relapse occurs and it goes above the baseline, and then there's a remission and the clinical symptoms go away and they're at baseline. This may occur several times. Importantly, there is then a relapse and then a remission. But as the disease progresses, the patient starts to have accrued neurological deficit. On the upper right-hand side is the secondary progressive MS. This is a type of MS that we talked about that many people will go on to have. But they have a relapse, the patient remits to the baseline, may have another relapse, but from then on there is secondary progression of the MS and an increasing residual, and they climb that ladder of the EDSS. The bottom left part of this slide shows the primary progressive MS, which I'm not going to talk about much tonight since we don't really have a treatment for it, but they gradually increase their residual aspects of their disease and they get more and more impairment. Progressive relapsing MS is where there is progression, but they have periods of a relapse, which occurs, and then they get a little better. But again, they have a significant increasing neurological findings. I'd like to review, before we start about clinical trials and treatments, the conventional MRI picture in MS and how we think about it. I'm not trying to make you radiologists, but what we need to know is some kind of concept about the MRI. Since it came about in 1983, here locally and other places, we've had a great advantage to look at the picture of MS on the MRI. In the upper left-hand corner, you'll see a MRI where the ventricles or the spinal fluid is white, and we call this a T2 lesion. And you can see the T2 lesions there around the juxtacortical region and around the ventricles. These are T2 lesions, which we'll talk about and are very important if they are present in an increasing number. On the right-hand side, in the upper right-hand corner, we have a picture we call a T1 gadolinium post-contrast MRI. And when the patient has contrast and these lesions light up, there is evidence of a breakdown of the blood-brain barrier, and there is active inflammation. This is an important concept and an important sign that there's active disease ongoing. The bottom picture shows us that this is T1 pre-contrast. And again, the spinal fluid in this looks dark. And what we have here is hypointense lesions. And we break that down into two important types of lesions. One is the acute hypointense lesion, and it looks like a dark hole. And about 50% of those will oftentimes resolve, and they may go away. They may turn into a T2 lesion. But many of them become chronic, and they're called chronic black holes. And when we have an increasing number of chronic black holes, it's strongly correlative with progression of disability in these patients. It also correlates well with cognition changes, and it represents the most important and most severe part of the axonal loss and significant changes that are occurring in the MRI. Now, this is a slide we talked about in phase 1. And it's the natural history of MS, and it's very important. It shows us 4 features of MS. This slide is orientated in a way which is very important, and on the left side we see preclinical aspect of MS, meaning the patient's not had any clinical features. Then we have the relapsing remitting part, and then we have the secondary progressive part. And through those 3 phases, we are measuring 4 important key factors. The white line is a measure of brain volume, and you can see in the preclinical phase, the brain volume is normal. In relapsing remitting, when there's activity and clinical symptoms, the brain volume starts to decrease. And in the secondary progressive, the brain volume decreases more. We call this cerebral atrophy. The blue line indicates relapses and impairment. So the patient in the preclinical phase has no relapses. But as we get into relapsing and remitting, you can see, again, there's a relapse. It goes up from the baseline. Then with remission, it comes down. It repeats itself. And then in secondary progressive, what happens is that there is fewer relapses, but there is significant accumulation of impairment. The red line is the MRI lesion accumulation, which we talked a little bit about. And that occurs early on, but as time goes on in relapsing remitting, there's greater burden, meaning more T2 lesions, more T1 hypointense lesions. And as you have secondary progressive, there's greater accumulation. And then the MRI activity is a yellow line, and you can see it's quite active preclinical. It definitely occurs in the relapsing remitting form, but then it kind of phases out or is less common in the more later part of the disease. This graph shows us that early relapses or more frequent relapses affect long-term disability, meaning that the more attacks you have in a certain period of time, the faster you progress. And in this slide, we see on the graph, on the left-hand side is a percent of patients. And on the bottom, or the horizontal, is a time from the onset of MS. And we can see here that what we're dealing with and describing is the percentage of patients not having reached DSS, or EDSS 6, which is impairment of walking or needing assistance. So what we look at is the yellow line, which says that there's only 0 to 1 attacks in 2 years. And we can see that it's shifted to the right, and that means that there is fewer patients that actually have reached the DSS of 6. And they're fewer, and they go a longer period of time until they get that disability scale. But when you have 2 to 4 attacks, then more patients will have disability, or another way to look at it is those patients have not reached a DEDS of 6, but what we have is in the green line that there are more patients that will get that EDSS of 6, and they get it quicker in a shorter period of time. This graph shows us that early relapses, or more frequent relapses, affect long-term disability, meaning that the more attacks you have in a certain period of time, the faster you progress. Now, there are predictors of poor treatment response, and the one I'd like to discuss in this slide is that of new lesions on T2-weighted MRI. And we like to divide this up into responders of treatment and poor responders. Now, there are other things that really indicate that, such as a short time to a new relapse or gadolinium-enhancing lesions. But I want to focus on the number of T2 lesions. Now, in this graph, you can see on the vertical is the percent of patients, and on the horizontal is the number of T2 lesions that are seen. And in this case, it was in a group of patients that were used and given interferon over 1 year. So we're talking about poor responders and responders. Now, the responders are in blue. So if you have no new T2 lesions, that means that you have a greater percentage of people that are good responders. And you can see in that first bar, it's very few that are poor responders. But as you have more lesions, like 1, 2, and 3, we can see the percentage of poor responders increase. So numbers of T2 lesions are important in indicating if the patient is a good responder. Now, I'd like to take a minute to give the history of MS drug release. And this is a busy slide, but I just want to show you a few things and associate name with the type of drug. And for example, beta-seron came out in 1993. Early on, we even had a lottery for that, but then the drug became more available. In 1993, beta-seron is interferon beta 1b. It's sub-Q every other day. Avonex came out in 96. It's an interferon, an immunomodulator like beta-seron. It's a beta 1a, and it's IM once a week. Then COPAXONE came out, a different kind of drug, not an interferon, and it came out in 1997. It's called glatiramer acetate. It's sub-Q daily, and it's an immunomodulator. Then a form of the interferon beta 1a is Rebif. It came out in 2002, and it's sub-Q 3 times a week. So more frequent dosing, and it's a bigger dose over a week period. Nivatrone came out in 2006. Mitoxantrone, it's IV, and I'm not going to discuss that much because it has a significant side effect of cancer cells that can occur in the periphery, and it can induce leukemia and other cancer types. Tysabri is a new drug that came out in 2010, a very robust drug, but it is an immunosuppressant. Unlike the other platform drugs, it's an immunosuppressant. Came out in 2010, Natalizumab. It's IV once a month. Xtavia is a form of an interferon beta 1b. And then came Gilenya. Gilenya was the first oral drug in this new group. It came out in 2011. Fingolimod, it's oral. We give it 0.5 milligrams every day. Aubagio came out in 2012. Teriflunomide, it's oral. We give 7 milligrams, then 14 milligrams Q daily. And Tecfidera came out. It's the newest drug. Came out in 2013. Early on, it was called BG12. Many people knew it by that. It's dimethyl fumarate. You start at 120 milligrams PO, or by mouth, and you go up to 240 BID. So that's the summary of drugs, and most of those are the drugs that we have today in our armamentarium. How do we have to think about the management or the treatment format in MS? And this is key. Patients have to understand this. Doctors have to understand it. But it's something that you really have to have as your foundation of knowledge for the treatment of MS. So first of all, and something I always emphasize, is early diagnosis, early treatment allows greater efficacy and the patients do better. I've talked about that for years. Disease-modifying therapy, or the platform drugs, by and large, is the first choice today. We also need to know in this treatment format to determine the risk-benefit profile. And that means very simply, what's the risk and what's the benefits, and you have to weigh that out. I like to use the triad called efficacy, tolerability, and safety. This is actually the triad that clinical trials give us: efficacy, tolerability, and safety. Safety sometimes is determined after the drug is out for some time. The patient and the doctor have to know and plan the treatment format early, so they have an idea what really is going to be. And as the journey of the disease shows itself, then you have a better idea. What may be in the future for the clinical course and treatment is very important. And another very important thing, the patient and the doctor have to coordinate together and have a known plan for monitoring and following a monitoring program. So the management format, very important. You want to control the disease and stop the progression. You want to reduce relapses. You want to know for each treatment this benefit-risk profile. You want to understand and know treatment as it is considered in what we call a tier status. We want to know that we have disease-modifying therapies, and by and large, we think of these as two types: immunomodulators and immunosuppressants. Some people like to divide it into first-line and second-line therapy. We know we have to monitor these diseases and the disease activity, and we have to really know if there's progression, and if it does occur, it's very important. Sometimes that's somewhat ambiguous about progression, but you have to have key signs and symptoms that fit. And you have to know the format for the clinical risk assessment. So I'd like to break this down about MS activity and its importance into two very important segments. One, clinically. So what do we think about clinically? I've referred to some of these. First of all, you have to think about relapse rate, and we term it annual relapse rate. Also, you have to think about time to the next relapse. If it's a shorter time to the next relapse, that indicates there's probably more active disease. Also, residual and severity of relapse and time to recovery. These are all key factors to determining the activity of the disease. And of course, progression. Now, in clinical trials, we talk about no sustained physical progression over 12 weeks. And that is a marker. Also, we have to think, is the treatment suboptimal? And how do you think about that? And then, is the patient a non-responder or is the patient a responder? And realize that the goal is optimized therapy. Now, also about the MS activity and its importance, I'd like to talk about the MRI. I've alluded to that. Earlier, we talked about what the MRI changes look like. So we know that gadolinium positive enhancing lesions indicate activity. And they are very important in assessing the disease process. And we also know that new T2 lesions are very important. Also, new or enlarging MRI lesions are important. So what we want to strive for is no new or enlarging MRI lesions. We talked about T2 lesions and the frequency and responders and non-responders. We also talked about T1 hypointense lesions. And we talked about brain atrophy. You saw that on the graph, that as the brain volume reduces, you get more brain atrophy. What is progression in MS? We like to define it in certain ways. So we know that the definition of a relapse is signs and symptoms that last longer than 24 hours. That means that a relapse is not just for an hour or two. It has to be 24 hours. We also know progression, as determined in the clinical trials, is designated so we have a constancy and we can measure it in some definite way. So by and large, it's used as progression is time to 12 weeks confirmed progression of disability. It's defined at least at 1 point increase from baseline EDSS, or if the patient has an EDSS of 0, it has to be 1.5 point increase, and it's sustained for 12 weeks. The concept of being able to measure progression gives some kind of consistency of understanding that as an endpoint. Now, what are the reasons for the lack of adherence to treatment in our MS population? This is an important concept because we know that if a patient isn't adhering to treatment, their outcome isn't as good. They have greater problems with relapses and also MRI increased activity. So here are some of the reasons. First of all, the patient experiences adverse side effects. Secondly, they have difficulty with injections. And if you have difficulty with injections, call the 800 number with these drugs. They'll help you with that. Thirdly, patient may be missing medication. They're just not paying attention to some kind of process where they make sure they take their medication. Another one is the patient and the family or caregiver have a lack of education and information. And of course, that's why we're giving these talks. So you can have greater education and information, and so you have a greater propensity to follow the medication as it should be given. There is also sometimes a lack of belief that the treatment has efficacy. And that's an important reason for patients not adhering to their medication, but that's one that you can overcome by education and talking with the doctor. And also some patients have a denial that they have MS, so they don't take their medication. Now I'd like to briefly talk about the very difficult concept of switching medications as the disease and journey of MS continues. And I'm going to talk about this just briefly. It's somewhat complex, but it's very, very important. And in some of the newer drugs, how you switch is really being modified and it's changing some. But let's talk about some of the simpler ones. For the interferon beta 1A or 1B to glatiramer acetate, the switch can be immediate. There's no problem there. And from glatiramer acetate to the interferon 1A or 1B, it's also an immediate switch. In glatiramer acetate or interferon 1A or 1B, when switching to Natalizumab, you have to get the baseline studies, but you can make the switch immediately. You need to have prior JCV virus titers, and there should not be probably any prior use of immunosuppressants. Now, when switching medications to some of the newer and more complex drugs, especially immunosuppressants, we have to be more careful. And Natalizumab, or Tysabri, when it's switched to glatiramer acetate or interferon 1A or 1B, there is no definite data, but most people feel that you have to have some washing out or a period of time when the drug has a chance to be eliminated by the body. Most people think it has to be numbers of weeks to up to 3 months. One of the problems with this, however, is that often after the natalizumab is stopped, the patient can have clinical and MRI significant worsening, and then this may need to be modified in some way, or you may have to use rescue drugs. Now, switching Fingolimod, Gilenya, to Natalizumab, or any other treatment, there's no real data. So we think at the present time that that can be done fairly quickly if the appropriate preclinical studies are done and the monitoring. Now, teriflunomide, or Aubagio, you have to consider some kind of washout. And the washout can be done in 11 days if you use the drug cholestyramine or activated charcoal. But there is actually not a great deal of data on switch. And then on dimethyl fumarate, or Tecfidera, there is really no data on that, but there are studies and consideration of data that's been evolving. Now, let's talk now about pathophysiology of MS. So we're going to talk about this and refresh our memory because this is key to understanding the treatment mechanisms of action. This is a little complex, but I want you to just hang in there with me, and you can always repeat it. So what do we know about the pathophysiology of MS? Well, first of all, it's an autoimmune immunological disease. So what happens is there is MS-specific pro-inflammatory immune cells that cross from the bloodstream into the central nervous system, and these pro-inflammatory cells, read here in this cartoon, secrete cytokines which are toxic, and they cause changes and destruction and demyelinization and axonal loss. And you can see in this cartoon that the red cells in the bloodstream then go through the blood-brain barrier, and they are into the brain, and they secrete these destructive cytokines and toxic substances, and it peels off the myelin, and it will then kill the axons. Now, the impact of the immune system in MS is very important, and we're learning more about this all the time. We know that MS is a debilitating autoimmune disease, and it's characterized pathologically by inflammation and axonal degeneration. And importantly, this is ongoing, as I showed you in that one slide, prior to the first events. Now, we need to some way regulate this immune system. So we're balancing this immune system, and we're reducing the effect of the pro-inflammatory cells and getting some anti-inflammatory cells, and maybe reducing these pro-inflammatory cells from going from the bloodstream into the brain. In this slide, you can see in the bloodstream there are red cells that are pro-inflammatory, and there are white cells that are naive, or they haven't been designated what they are, and there are some anti-inflammatory cells. And these cells, in some way, can get into the bloodstream. Now, we know that these cells originate somewhere as lymphocytes in the lymph nodes, and then they have some mechanism that changes, and then they get into the bloodstream. So in the bloodstream, we have pro-inflammatory cells, which are in the red, and we have blue anti-inflammatory cells. And in MS, there's a lot more pro-inflammatory cells that can get into the brain and excrete cytokines. The immune dysfunction is significant, and there are 4 key features to this. There are the pro-inflammatory immune cell in red. They excrete pro-inflammatory cytokines. There's an antigen-presenting cell, and there are T cells. Now you can see in the bottom part of this cartoon, that's the bloodstream, and these red cells are there, and there's some T cells. This antigen-presenting cell activates some of these cells, especially the pro-inflammatory, and it allows those cells to go through the blood-brain barrier, which is in some way probably weakened, and these pro-inflammatory cells get into the brain. Now first, let's talk how this system works in the mechanism of action of COPAXONE, or glatiramer acetate. Remember, it's an immunomodulator. And what happens with COPAXONE? This drug induces a population of regulatory T cells, which come from the lymphocytes, and they are in the bloodstream. And these T cells are induced to turn into anti-inflammatory cells, and they get into the brain, and the anti-inflammatory cell gives off cytokines and possibly neurotrophic factors that somehow help sustain and are beneficial in helping reduce the demyelinization and the axonal loss. And through this mechanism, there is some type of prevention of demyelinization and nerve damage. Now, this is a little different slide, but it shows you a little bit what we're talking about with the glatiramer acetate. On the left-hand side, in the bloodstream, you have the glatiramer acetate, and that has an interaction with the antigen-presenting cell, and in some way it induces this T cell to becoming a Th2 anti-inflammatory cell, and then that gets in through the blood-brain barrier, and it allows the production of the anti-inflammatory cytokines and also gives some kind of neurotrophic factor release, and we call that bystander suppression. And that's being worked out more. So that was COPAXONE. Now let's look at what the presumed mechanism of action is of the interferons. Again, an immunomodulator. And we have the same characters or actors, pro-inflammatory. We have the antigen-presenting cell. We have T cells and pro-inflammatory cytokines. And what happens with the interferons, it reduces the number of pro-inflammatory cells and hence reduces the pro-inflammatory cytokine levels inside the brain. So some way interferon blocks that trafficking of the pro-inflammatory cells into the brain and hence reduces the demyelinization and axonal loss. Now, Natalizumab, the presumed mechanism of action, is in this immunosuppressant, is that it blocks this trafficking in a very unique way. What happens with Natalizumab or Tysabri, through a complex mechanism, it inhibits the alpha-4 mediated adhesion of the lymphocytes, which are actually these potential inflammatory cells, to the vascular cell adhesion molecule on the lining of the bloodstream, or the lining cells, the vascular cells. It blocks that adhesion, hence they can't get into the brain, and this is the concept of reducing this trafficking of these pro-inflammatory cells. So it strongly reduces this pro-inflammatory cell recruitment, but it also may inhibit some desirable cells that get into the brain that may affect the viruses that may be there, especially the JC virus, and hence that may be the reason there is increased amount of PML in patients treated with Natalizumab. Now, Fingolimod or Gilenya works in a different way, and what it's thought is that in the lymph nodes, it modulates this syringosine 1-phosphate receptor on the lymphocytes, and it kind of sequesters these lymphocytes in the lymph node, hence reduces the population of pro-inflammatory cells, and consequently it reduces the number of pro-inflammatory cells that get into the brain. That is the mechanism that is thought to play a role in Fingolimod. Now, we have discussed the medication, and we've talked about the mechanism of action, and we're going to talk now about clinical trials. Most of the clinical trials started in the late 1980s and were completed in the mid-1990s, and that's when these drugs were released, the platform drugs. Now, the natural history, which means how MS acted prior to any treatment, usually is significant that the annual relapse rate showed about 1.7 relapses per year. There's some Queen Square in England data that showed there was about 1 relapse every 1.5 years. So when the early trials were done, patients had a significant number of years. They'd already had MS, and they probably had an increased number of relapses, and they also had significant demyelinization and axonal loss. So more recent trials that have been done have probably had a shorter disease history and have had less MRI burden. Now this is a graph that is very helpful. It's also very colorful, but what it shows here is the annual relapse rate over a period of time. And this is across clinical trials. So each bar indicates a clinical trial. Now in this graph, the vertical is the annual relapse rate, and the horizontal are the various trials. And I'm just going to go through a few of these, but it's important to remember that the natural history was the annual relapse rate was somewhere around 1.7 in most studies. So the first 4 bars on the left-hand side, these were the platform drugs. So the first one on the left, after the drug was given, that was glatiramer acetate, had an annual relapse rate of 0.59. And then Avonex had 0.67, and then betaseron, and then Rebif. So they were all about the same. They reduced the relapse rate by about 30 to 35%. So those were the platform drugs. And that's why I mentioned some of these patients that were treated had a greater disease burden and probably had a more severe MS condition. Now then came Fingolimod, which is the small bar that is red, and you can see the annual relapse rate there after treatment significantly dropped. Then came Tysabri, and that was 0.23, and then came some trials that gave comparison to active drugs that were in the market, such as Rebif and glatiramer acetate, which was the Regard trial, then the Beyond trial, which was betaseron versus glatiramer acetate, and you can see these relapse rates were significantly lower, 0.34, 0.35. So we're making better progress and reducing the number of relapse. That is the most important thing that this slide shows. Now, after discontinuing any drug, there is a significant risk of the patient not doing well. And this is an example of COPAXONE, but it could be other drugs, that in data that is a 10-year follow-up, it shows in this graph that patients that were clinically stable or improved when they kept on the drug was 55%, but when they stopped the glatiramer acetate, that dropped down to 28%. So the slide tells us in all medications you need to continue to take your medicine unless there's some significant reason why. And then oftentimes you need to switch to another drug. This slide is very interesting because it shows us there is a reduction in the annual relapse rate following change in therapy. So there are 4 different therapeutic formats here. On the vertical is the annual relapse rate, and on the horizontal are the different studies that were done. And I'd just like to mention this because it tells us that if you are on one drug and you're not doing well and you switch the drug, you have a very good chance of having a significant reduction in relapse rate. So on the left-hand side, it's interferon to COPAXONE, and you can see when it was switched, it was a 77% reduction in relapse rate. The next one, low-dose interferon to high-dose, significant reduction rate. And then COPAXONE to interferon, there was a significant reduction rate of the annual relapse rate. So switching the drug can be very beneficial. Now the next group of slides, what I'd like to discuss here, is the safety information. There's a lot of data on this. I'm going to kind of summarize it for us, but it's important data. Patients need to know this. So the first slide is on COPAXONE. On the left-hand side, it is what is the safety concepts and what is the side effects that COPAXONE may be associated with. Well, they can get an immediate post-injection reaction, lightheadedness, chest pressure, a little dizziness, but that usually goes away quickly and rarely reoccurs. You can have injection site reactions with COPAXONE because it's a sub-Q injection, and you can have lipoatrophy where the sub-Q fat cells kind of are atrophic and you get a little dimpling. But COPAXONE is not associated with usually infectious diseases that become significant. PML, it's not associated with depression or liver abnormalities or anaphylaxis events. COPAXONE is a pregnancy category B, so you have to be cautious, but it has a little less risk than some of the others. Now, what is the safety information on high-dose interferon? Well, on the left-hand side, we can see it's associated with injection site reactions. It's sub-Q. It has some flu-like symptoms. Depression has to be considered. And with rebif, you have to be concerned about hepatic injury. And it's not associated with some of the important aspects that is seen on the right-hand side, in that infections aren't much of a problem or need to be considered, and lipoatrophy is not a concern, nor is PML. High-dose interferon beta 1A or 1B is pregnancy category C. Now, natalizumab is a little different kind of safety information. It's associated with this disease that can be progressive, called progressive multifocal leukoencephalopathy. And we'll talk about that briefly. You have to be concerned about an immunosuppressant phenomenon because Tysabri is an immunosuppressant. And pneumonia, urinary tract infections have to be considered and have to be monitored for. And it can have significant hepatic injury. Anaphylaxis is a concern, and that's a very important consideration, especially in the infusion centers. Tysabri is not associated with, obviously, injection site reactions or the flu-like symptoms, and it doesn't have lipoatrophy. Tysabri is a pregnancy category C. Now, why are we having all these new MS drugs? And I'd like to discuss that briefly. Well, first of all, we don't have a cure for MS yet. Hopefully, we'll have it soon. It may have many combinations of causes, meaning the etiology may, because we have a heterogeneous group of patients, and they may have lots of significant different comorbidities. MS is an evolving disease with a journey that may have various degrees or types of pathophysiology. We're not sure of the various types. And again, comorbidity may be acquired as the patient goes through their journey of disease. And these drugs have different mechanisms of action. And we do not know all the specific types of mechanisms of action they may have. They may have more than one. Also, we have new drugs because some of these drugs will become less effective, or the patient will have suboptimal therapy, and or they may create side effects and or can't be tolerated. Also, some may have better efficacy risk profile than others, and there may be a cost advantage in some as compared to others. At the present time, there's not a great deal of cost difference. It has to be remembered it takes 100,000 patient exposures to determine the infrequent adverse side effects or events in any disease, process, and treatment format. So let's talk about endpoints and trials. Now, when you do a trial, you have to have some way to determine if there is an improvement in that patient population. And we call those endpoints. And in trials, we usually compare placebo versus drug, or sometimes we compare an active drug. So we're thinking about the order of outcome analysis. And I'm going to use that in a specific order in these slides so we don't get confused and I don't get confused. It's going to be a little complex, but you can use this as a comparison sometimes, but remember you can never compare clinical trials because you have a different group of population and a different group of placebo patients. So how do we think about this as endpoints? One, we use annual relapse rate, which we've already talked about, and it's usually given at 1 or 2 years. Number two, time to first relapse. 3, we use relapse-free at 1 or 2 years as a criteria. How many patients are relapse-free? And then we look at MRI data, relative risk reduction for the various kinds of markers. And then, as I mentioned, this kind of complex concept of progression, we use reduced risk of sustained disability progression for 12 weeks, and that's usually given as a percentage. So the first drug we're going to look at is the newer drug called Tysabri or Natalizumab, and the trial was the Affirm trial. So remember how we're going to look at these endpoints, and they'll be in order. So this drug was about 900 plus patients. It was randomized 2 active patients to 1 placebo. It was an infusion since it's IV. It's an immunosuppressant. And many of these patients were infused for many, many weeks. So the outcome, annual relapse rate endpoint at 2 years, in placebo patients, they had 0.67. But in the Natalizumab group, it was 0.22, a robust reduction of 67%. Patients that had no relapses at 2 years, placebo 41, but in Natalizumab, it was 67%, and no relapses at 2 years, the higher percentage, the better. Gadolinium positive lesions at 2 years, it was reduced by 92%, very robust. Free of gadolinium positive lesions, placebo 72%, and Natalizumab 97%. Again, the higher percentage, the better. No new enlarging T2 lesions, again favored Natalizumab, and the reduced risk of disability progression sustained for 12 weeks was reduced by 42% when you compared placebo to Natalizumab. Now, progressive multifocal leukoencephalopathy is a progressive disease that is very devastating, and it's seen in patients who are treated with Natalizumab or Tysabri. And now it looks like there's about 120,000 patient exposures with Natalizumab throughout the country. We have PML, or progressive multifocal leukoencephalopathy. About 300 cases out of that group acquired PML. The survival rate is about 78%, so most survive, but about a third have mild neurological deficit, a third moderate, and a third severe neurological deficit. So it's a significant disease that can have significant neurological complications. But importantly, if you consider 3 risk factors, you can reduce this incidence of PML. And what are those 3 risk factors? Patient has a positive JC virus titer, if the patient has prior immunosuppressant medication, or if they've been on the drug greater than 24 months. Those are the 3 risk factors. And we'll talk about those a little bit more. We like to have an anti-JC virus antibody titer before we use this drug, or at baseline, and we like to use that titer and reconfirm its negativity every 3 to 6 months. So how do you consider these 3 risk factors? And it's important to know these 3 risk factors because you don't want to get PML. The first one is you want to have an anti-JC virus antibody titer. Now, in the population, it's not uncommon to be positive in this anti-JC virus antibody titer. In fact, up to 50 to 60% of the population may be positive. They can acquire the disease. It can be positive in the serum, and you can have it in the urine. Patients may convert while they're on the treatment from negative to positive or through a new exposure. I sometimes, when I'm thinking my format of treatment ahead of time, I will get an anti-JC virus antibody titer earlier when I'm thinking of my treatment format ahead of time. Now, the second important risk factor is that they've been treated previously with immunosuppressants, and I've listed those. These are immunosuppressants. They increase the risk of developing PML. And then the third factor is longer treatment duration beyond 1.5 to 2 years. And you can see now that what we need to consider is how those all fit together. This slide's a little complex, but it has a lot of information in it, and it's very key. And you can refer to this slide anytime when you revisit this video. So if you have a positive JC virus and you've been treated for less than 2 years and you've had no immunosuppressant therapy, your risk of developing PML is less than 1 in 1,000. So the risk isn't great. If you've had a positive JC virus antibody and you've had an immunosuppressant drug, your risk is 2 in 1,000. But here is the important concern for greater risk. If your JC virus antibody is positive, and everybody's got to get that prior to they start on this drug, Tysabri, and your treatment is longer than 2 years, and you've had no immunosuppressants, your risk is 5 in 1,000. But your risk is much higher if you have a positive JC virus antibody, you've had the treatment longer than 2 years, and you've had immunosuppressants. It's 11 in 1,000. Risk is greatly increased. So what is PML? Progressive multifocal leukoencephalopathy. It's a bad disease. It has demyelinization, inflammation, axonal loss, and it's very important to avoid. You need to have a prior exposure to JC virus, and that's required for the development of PML. But oftentimes people have this in their brain, and it's latent. So we talked about the number of people that can have it in the normal population. If the patient has progressive multifocal leukoencephalopathy, the clinical picture is usually that of a neurological progression. They can have any signs and symptoms, but it's often a localized change, and speech and behavior changes are key. You need to probably monitor some of these MRI cases if the patient is positive for the JC virus and you feel like you need to keep this patient on that Tysabri. Now, with PML, there's more focal MRI changes, and the gadolinium-enhancing lesions are more common. To exclude PML, you have to have a negative JC virus DNA in the spinal fluid, and that requires a spinal tap. And you have to repeat CSF quantitative PCR assays for the JC virus DNA, and the patient has to have no clinical progression. And that's in patients who you are concerned about having PML. The latter part of this slide is mainly for the doctor. This is an MRI of PML, and you can see that there is a localized area of abnormality. PML is a disease that involves inflammation and demyelinization and axonal loss. Sometimes we'll need to switch from Natalizumab or Tysabri, and there will need to be a washout. However, exactly how long that is now is uncertain, and there's evolving data and evolving suggestions, but it will somewhat depend on the aspect of a progressive course after the discontinuance. We need to observe very carefully after Natalizumab is discontinued for clinical or MRI worsening. Oftentimes there is increase in disease activity and an increase in relapses and or progression. When you have MS, and with all the new drugs, there's going to be a consideration of switching drugs from one to another. I've talked about you cannot compare clinical trials, but this will give you evidence of the efficacy in a clinical trial. So we'll talk about Fingolimod or the Freedoms trial. Now Fingolimod or Gilenya, this trial had about 1,272 patients in. It was 2 years in duration, oral. It used 0.5 milligrams, and it had an arm of 1.25 milligrams versus placebo. I'm only going to talk about the data for 0.5 because it's the only dose that's out on the market. So again, we'll go over in a sequence the endpoints. Annual relapse rate was reduced by 54% for the 0.5 milligram, robust benefit. Relapse-free, placebo was 46% versus Fingolimod was 70%, a reduction by 52%. The number of T2 lesions reduced was significant. It was an absolute reduction, was 7.3 lesions in these patients. And also there was reduced risk of disability progression, maintained for 12 weeks by 30%. Now, the Transform trial using Fingolimod was a one-year trial, and this was a different type of trial because it compared the 0.5 and the 1.25 milligram dose of Gilenya to interferon beta 1A IM once a week, which is Avonex. The data I'm going to compare is 0.5 milligrams. So the annual relapse rate showed that the interferon beta 1A had an annual relapse rate of 0.33, but the Fingolimod group had a relapse rate of 0.16, or a 52% reduction. Relapse-free, interferon was 70%, and Fingolimod was 83%, not too robust, but was a 19% reduction. The number of T2 lesions reduced in the interferon group was 2.6 versus Fingolimod 1.6. So you can see here in multiple endpoints and parameters, there is a significant improvement. And this slide shows the efficacy in annual relapse rate. So it's a bar graph showing much the same thing. On the Transform trial on the left, the vertical line is the annualized relapse rate, and on the horizontal, it is the interferon and the 0.5 and also the 1.25, but we're going to concentrate on the 0.5, and it shows the annual relapse rate was 0.16. And we talked about the percentages. On the Freedoms trial, which compared their placebo, the annual relapse rate was only 0.16 for the 0.5 and 0.40 for the placebo. Now, Fingolimod is somewhat complicated in its precautions. That is probably due to the fact of the syringosine receptor is in multiple areas of the body. So we consider Gilenya contraindicated in patients with ischemic coronary artery disease, MIs, unstable angina, strokes, TIAs, congestive heart failure, and patients that have abnormalities in their EKG or arrhythmias, or if they're on certain anti-arrhythmic drugs. Fingolimod may increase the risk of infections, and it does reduce the lymphocytes to about 20 to 30% from baseline, and when the drug is stopped, will usually recover in 2 to 3 months. But remember, you need a baseline white count in this drug prior to treatment. Macular edema is a side effect, and you can have that with or without visual signs or symptoms. And it can be associated with reduced pulmonary function, and that may occur with the treatment. So what are the precautions? Liver enzymes may become elevated. There may be reduced lymphocytes. And of course, the patient should not be pregnant. So appropriate birth control to prevent pregnancy needs to be carried out. You have to stop the drug 2 months before pregnancy, and it is a Class C pregnancy category. You have to monitor closely if they're on certain antibiotics, and side effects such as headaches, influenza, diarrhea, back pain, elevated liver function tests, as I talked about, and cough can occur. So we consider certain pre-use workup for Fingolimod. We talked about it. You have to have a recent white count and a liver function test. You have to have an ophthalmological evaluation to make sure about macular edema. You have to do that pre-use and also during its treatment. Cardiac evaluation, if the history or medicine suggests, and if there's a history of chickenpox or varicella zoster, or there's a positive serology or positive antibodies to varicella zoster, and that is okay for the patient to have the drug. But if they aren't positive, they haven't had the history, they have to have a vaccination for the varicella zoster virus if antibodies are negative. Women have to be on contraceptives 2 months before the treatment of the drug and during the use of the drug and for 2 months after discontinuing the drug. So what do we do for the first dose? It has to be some type of format of monitoring. So we divide that into 6-hour monitoring and overnight. And the 6-hour monitoring is done with blood pressure and EKG before and after the first dose. And if the patient doesn't have a severe, significant history of coronary vascular disease, or they have a slow heart rate or prolonged QT interval, then you just monitor them for 6 hours. But if they have any greater risk for cardiac aspects or syncope or abnormal EKG, or if they're on any drugs, then they got to have an overnight monitoring of blood pressure and cardiac and EKG changes. We also need to monitor this drug and other signs and symptoms that may occur with the use of this drug. We talked about macular edema. You have to monitor it before, and you also check it during the use of the drug. Macular edema can occur 1 in 500, and as I said, there may or may not be visual symptoms, and it occurs more in patients with diabetes or a history of uveitis. You have to consider monitoring pulmonary function. You're always going to monitor blood pressure regularly during the use of the drug, and watching the white blood count for reduced lymphocytes and decrease of those lymphocytes is important. And that decrease may last as long as 2 months after discontinuing the drug. Let's talk about the next new drug, which is teriflunomide. And again, I'm going to use the same program of measuring these endpoints. But what is teriflunomide, or Aubagio? It's indicated for relapsing forms of MS. Teriflunomide is the principal active metabolite of leflunomide, which is a drug that already is indicated for rheumatoid arthritis. Leflunomide, when it was used in the treatment of rheumatoid arthritis, was associated with liver injury. So you have to have liver function tests, and they must be done prior and during the use of teriflunomide, and that's an important consideration. Pre-existing liver disease, such as infectious or alcohol, or the use of potent hepatotoxic drugs, may increase the liver function tests that are being monitored. Teriflunomide's trial was a TEMSO trial, and there were about 1,000 patients. It's an oral treatment. Compared placebo with teriflunomide 7 milligrams and 14 milligrams. There was robust efficacy when using 14 milligrams, and there was about similar side effects. So let's talk about the annual relapse rate, again looking at these endpoints. The annual relapse rate in this trial for Aubagio or teriflunomide at 2 years, it showed placebo had an annual relapse rate of 0.54 versus teriflunomide, which was 0.37 for the 14 milligram, which is the standard drug dose used. That's reduced by 31%. In a 5-year extension, the annual relapse rate was 0.26. The 12-week sustained disability progression at 2 years for placebo was 27.3% versus teriflunomide was 20.2%, or a reduction by 30%. Now, the TEMSO trial showed that there was significant benefit in the MRI endpoints. So the total lesion volume reduction was significant, and that was T1 hypointense plus T2 hyperintense, and placebo was 1.13 versus 14 milligram dose was 0.35. The relative risk reduction was 69%. T1 gadolinium enhancing lesions were reduced. The reduction rate was 80%, which is fairly robust. And in another monitoring endpoint, there was a 64% reduction favoring teriflunomide. There were some significant side effects, but by and large, there was about the same for placebo and teriflunomide considering discontinuance rate. There was some diarrhea, nausea, there was some liver function test elevation. For placebo, it was 7%. For teriflunomide, it was 14%. But the need to discontinue because of liver function tests was about the same. One of the side effects that is noted is hair thinning. And in placebo, only 3% developed hair thinning, but in teriflunomide, there was 13%. But the discontinuance rate was only about 1%. This hair thinning peaks at about 3 to 6 months, then oftentimes gets better. There's spontaneous recovery with teriflunomide in most cases, and 94% recover without any sequelae. You have to watch for possible peripheral neuropathy, some kidney difficulty, elevated potassium levels, skin problems, and possible infections. Now this graph showed what I talked about for the annual relapse rate. And you can see there are 3 bars, and placebo, the annual relapse rate was 0.539, but for the 14 milligram, it was 0.369, hence a significant reduction in the annual relapse rate. And this is a nice graph that shows the disability progression. And on the vertical, you can see it's the disability progression percentage. And the horizontal is actually the number of weeks. And you can see by the light blue lines that there is a reduced progression in disability in the number of patients when you are on teriflunomide. In another trial called the 10-year trial, there were 324 patients. It compared interferon, Rebif, with teriflunomide, and there was no significant difference in annual relapse rate or in time to failure. The discontinuance rate was importantly favored teriflunomide. More people discontinued interferon, and there was more liver elevation in the interferon group than there was in the teriflunomide. Now, how do you monitor patients prior to the use of teriflunomide? Well, you have to perform a pregnancy test, check the liver function test, and the CBC test within 6 months. You have to do a tuberculosis test. You have to monitor the blood pressure. And after starting teriflunomide, you have to monitor the liver function test every month for 6 months. And you have to monitor any added medication and check the blood pressure. Aubagio or teriflunomide is a pregnancy category X, and it's based on animal data. And if you get pregnant, you should involve the pregnancy register, talk to the doctor immediately. There have been 12 live births on the trials, and all of the babies were healthy. So in females who take the drug, they need to have a pregnancy test before, and then they got to have adequate birth control for 2 months before starting the drug and after stopping the drug. And the males who are on the drug should have some adequate birth control also. If there are any pregnancies, you got to notify the doctor, and also you need to lower the drug blood levels, and you do this by 11-day treatment with rapid elimination with cholestyramine and activated charcoal. Now, the next drug we're going to talk about is dimethyl fumarate, or Tecfidera. This was called BG12. It's a defined trial. I'm going to go through this very same sequence, organized endpoints. It was about 1,237 patients. It was an oral drug. It was placebo compared to 240 milligrams twice a day. They did 240 milligrams 3 times a day in this 2-year trial, but I'm only going to talk about the 240 BID because it's an approved dose. The annual relapse reduction for 240 twice a day dose was 53%. The reduced risk of relapse at 2 years was 49%. Gadolinium enhancing lesions were reduced was 90% from the active drug compared to the placebo. There was a significant reduction in T2 new and enlarging lesions. It was reduced by 85%. And T1 new hypointense lesions were reduced by 72%. And the reduced disability progression was by 38% at 2 years. Another trial called the CONFIRM trial added glatiramer acetate as one of the arms. But I'm just going to mainly emphasize the comparison of placebo to dimethyl fumarate. And in the annual relapse rate, the dimethyl fumarate was reduced for the BID dose by 44%. And the percent of patients relapsed on the BID dose was 34% as compared to the placebo. Glatiramer acetate reduced it by about 29%. But there was a difference in the reduced disability progression. For the BID dose, it was 21% over placebo, and for glatiramer acetate, it was 7%. In the confirmed trial, in the MRI endpoints, in the T2 new and enlarging lesion reduction, the active drug dimethyl fumarate had a 71% reduction in these lesions. And in T1 new hypointense lesions, it was a 57% reduction over the placebo. What are the side effects of dimethyl fumarate? One is flushing, and it's a very common side effect. 40% of the people will get that. People will get a warm, red, itching, burning sensation, and it can be reduced by taking food or taking aspirin. You can have nausea, vomiting, diarrhea, abdominal pain, or dyspepsia. You also may develop some lymphopenia. That's why you have to have a baseline white count and repeat it intermittently, especially at 1 year. And you can also have a headache or some nasopharyngitis, and dimethyl fumarate is a pregnancy category C. What is the mechanism of action? Well, it's not completely worked out. It's an oral drug. We talk about we're giving it 2 times a day. You start out at 120 milligrams twice a day for 7 days, and then 240 milligrams. It probably activates a pathway which is named NRF2, which probably reduces the impact of inflammatory cells in the spinal fluid. However, that is not known for certain. It probably induces direct cytoprotective responses in the cells and may balance out this pro-inflammatory state we talked about. Remember those red cells that are increased that excrete cytokines that are toxic and destructive to myelin and axons. Going from dimethyl fumarate to other treatment, it's not certain if there needs to be a washout. The drug is out of the system in about 24 hours. So let's change gears and talk a little bit about rescue therapy. And we're getting to the end of our talk, but rescue therapy is important. That means when a patient has a sudden significant relapse, can you help rescue them out of that? Well, the first is methylprednisolone, 1,000 milligrams IV for 3 to 5 days with or without an oral taper. Or you can try oral prednisone, 60 to 100 milligrams for 5 to 7 days. However, not all patients really have a significant, robust response to that. And it's thought about 30 to 40% of the patients who are treated with this relapse are not improved with above treatment. Actar is an ACTH gel. It's a steroid-like that can be given IM or sub-Q, and it can be injected by the person or by a friend or caregiver, and you give it daily for 2 to 3 weeks. It is thought that it works by binding to melanocortin receptors in the brain and suppressing the cytokines. I would like to now talk about MS treatment algorithm, or apply an algorithm to various forms of MS. And remember, we talked about various forms of MS. We talked about IRS, which is radiologically isolated syndrome. Then we talked about CIS, clinically isolated syndrome. And then we showed the graph of relapsing remitting MS and secondary progressive MS. So let's focus on radiologically isolated syndrome. What is that? Radiologically isolated syndrome is when the patient comes in and they get an MRI for some reason other than a symptom that would sound as if it was MS, like a patient coming into the emergency room after trauma. And the doctor finds on the MRI a picture that could be consistent with MS. So that's called radiologically isolated syndrome. And we talked about any two, any new. These are lesions on the MRI. Any 2 lesions in appropriate areas, and any 2 and any new. So you have that MRI, radiologically isolated syndrome. How do you handle it? Well, you determine if you have the correct diagnosis of radiologically isolated syndrome. And so you do that by doing a spinal tap to see if there's abnormalities that support MS. And then you may repeat the MRI. If I think the patient has radiologically isolated syndrome, and this may be a controversial part of treatment for this form, and I think the diagnosis is that, or if there's gadolinium-positive lesions, or there's some history that may sound like MS, I will go ahead and treat the patient with a platform drug. If I don't treat him, then the patient needs to be followed very carefully and have a frequent MRI to see if there's activity that's new in the MRI to fit that concept, any two MRI lesions. Then we have another form of MS called clinically isolated syndrome. And what does that mean? That means one symptom of MS that fits with the signs and symptoms and an MRI that looks like MS. Any two, any new, the lesions are T2, they're enhancing, they're juxtacortical, or in the brainstem or cervical area, or paraventricular. And in those cases, I aggressively use disease-modifying therapies. And I'm very aggressive about that because all the studies that have been done in clinically isolated syndrome show that you delay the time to clinically definite MS. So I treat them aggressively, and then I repeat an MRI in 1 year, or when there's a relapse or a progression. And then we have relapsing remitting MS. And in these cases, I use disease-modifying therapy, platform drugs first. They're immunomodulators, and I follow them closely. And if there's relapses or MRI changes showing new activity, new lesions, and I showed you the slide on the more frequent T2 lesions and the more activity, or gadolinium-positive lesions, then I consider changing the disease-modifying therapy. Now, in relapsing remitting MS, and when there is significant change in the burden on the MRI, meaning more lesions, or we're having more frequent relapses, or they last longer, or the residual is significant, or they start to progress neurologically in their neurological deficit, I will change the treatment format. And oftentimes, I will treat with a more robust drug like Natalizumab. Now, that's an immunosuppressant. It has greater risk, PML. But I will go to that drug, and if they're JC virus positive, or they've had immunosuppressors before, and I'm concerned about using Natalizumab, that it has more risk factors for PML, I will consider going to another drug. And that drug would be Fingolimod, teriflunomide, or dimethylfumarate in no particular order, measuring the benefit-risk ratio and considering that very important. Then, if they're having a significant relapse, I'll use methylprednisolone IV or Actar as an indicated drug for rescue. Now, interestingly, people talk about using interferons and glatiramer acetate together, but there have been trials that show that that is no benefit. There are some third-line drugs, and they are mesantroin and other monoclonal antibodies. Cladribine is not released, but we always have used, in some cases, cyclophosphamide, which is Cytoxan. We used that aggressively in the mid and early 1980s. There are some experimental monoclonal antibodies, which I'm not going to talk about, and they're always experimenting with bone marrow transplant. I think that, at the present time, is a treatment format with all these new drugs is one that we would not be using. Now, there is another monoclonal antibody, and it's alemtuzumab, and it is an anti-CD52 monoclonal antibody. And it's been shown to be a benefit, and it has some side effects. And I put that here on this slide to show you some of those aspects, but I'm not going to detail that now. You have to be concerned about infusion-associated reactions and infections. But there was some improvement in the annual relapse rate and relapse-free at 2 years. So we have talked about most of the treatments that we have available for the treatment of MS. I just want to mention some future treatments. Laquinimod is an oral drug that shifts Th1 cells to Th2, but it wasn't very robust. It may be considered as an adjunctive therapy for neuroprotection. There are more monoclonal antibodies present now in research, and there'll probably be more that'll be in clinical trials. There's a pegylated sub-Q beta-1A that may be used. It may have some benefit. It has a longer half-life. Stem cells are always being talked about, and that's certainly a consideration. But right now, I think that we're really dealing with basic science data. And of course, T-cell vaccinations have been considered, and there's some evidence they reduce annual relapse rate, but they're at the present time without MRI benefits. And one of the important treatment formats that everybody can do that has little or no risk is exercise. Exercise in a very significant manner, 60 to 80% your maximum heart rate for an hour a day for 5 to 6 days a week has been shown to be a benefit in neurodegenerative diseases like Parkinson's, maybe in Alzheimer's, but there's evidence now it's certainly also considered as beneficial in MS. Not only does it help possibly generating neurotrophic factors to reduce the progression of the disease, but it helps the patient to be generally in better condition, and it may reduce other comorbidity. Now, I know some of you are thinking, why do I need to know all this data? Why should I know about annual relapse rate, the significance of relapse, the significance of progression for a certain period of time? Why should I know about MRIs? Because healthcare is changing. We need to have all the information in all the areas of the treatment and therapeutic aspects of healthcare today. And you need to be your advocate. You need to have responsibility for your disease because we really need to have you as a participant. You need to be on the team. So a lot of this was esoteric, a lot of it was data, but you really need to know some of this for your better quality of care. So thanks a lot for joining us. I hope this is a benefit. Spread the word so everyone can have an opportunity to have a foundation in the understanding of their MS and help their healthcare process. Thank you. This series of programs has been funded by the generosity of the Bell Foundation in honor of Glenn W. Bell Jr., founder of Taco Bell, and by Elaine and David Darwin.